So I'm going to talk about cannulation, I'll talk about cannular failure, the role of difficult intravenous access as a patient cohort and ultrasound guidance. I will then talk about the implementation that we had at Aintree Hospital over a 4-year period, patient assessment, vessel assessment, technique, which is really important when it comes to ultrasound-guided cannulation, and then finally the advantages and disadvantages of using this technique and device. So, why is it important to us? Why should we care about cannulation? This is because it's so used in healthcare. Almost all patients in hospital, and increasingly so in the community services, will have a cannula for intravenous therapy. It is essential for the safe and reliable delivery of intravenous access. However, it is plagued with high failure rates. And we need to remember that any vascular access device is a risk factor for gram-negative bloodstream infections and other bloodstream infections. So let's look at the definitions. There are some variances in the definitions of what a peripheral device is. So the first point you can see is that in the US, they define a short peripheral cannula as less than 3 inches in length, which I think from memory, I'm in new money, is about 7-ish centimeters, okay? And then we've got the INS who say that it is a catheter over needle insertion into the superficial veins, which I will talk about in the context of what we did a little bit later on in the presentation. We've got the European guidance, which we kind of go against, which is the Peripheral consensus, I think it was. I'm sorry if I've pronounced that incorrectly. Where basically a short peripheral cannula needs to be less than 6 centimeters in length to be within that definition. So we are already breaking the rules in that way. Indications. There are some variances in the indications for peripheral cannulation. Some say it should be for up to 6 days of treatment and then we should move on to a more invasive device. Some say 7 to 10 days and then we've got the Vessel Health Preservation Framework which mention that it can stay up to 14 days when inserted with ultrasound. The problem we've got with cannulas is that they fail so often. And premature failure is basically failure before the intended treatment of completion of treatment. Now, this can be a little bit ambiguous because obviously some patients go on to then to have a different type of vascular access device. But from the start, if you're planning to give some treatment for short term, the cannula is the device of choice. We've got up to 50% of cannula fails, but this also does differ. That some literature reports different rates of cannula failure, but also is dependent on lots of different factors. In America, they discuss a 10% dislodgement rate, so there's a high dislodgement rate, but then we've got all the other cannula failure problems as well. And actually, failure is actually multifaceted. If you think about just one infusion that goes into one cannula in one patient, if we think about those things, there's a lot of things that can go wrong because you've got multiple points of failure. You've got the infusion that is going through, the bag itself, how it was made up, whether they used ANTT to make up their medication. You've then got attached to a pump, if the pump is functioning as it should do, if it's set up in the correct way. Then you've got it attached to a piece of plastic that has got lots of technology within it itself, and then you've got it into a vein in a patient's body. So there is multiple points of failure here, and I actually think that when you think about those things, I don't know if it's much of a surprise that so many cannulas fail. And then you've got the effect of the infusion on the patient's vessel itself when it goes inside the patient. There's complications from phlebitis, which itself can be mechanical, infective, or chemical. We've got disconnection of the multiple parts in that infusion as well. So there's so many things that can go wrong. I actually think it points to the fact that peripheral cannulation and delivery of intravenous therapy is actually a very complex thing to do in healthcare. So what's the impact of cannula fail on the patient and the healthcare professionals and the organisation? So if we have PIVC failure or cannula failure, we usually have more than one cannula, and that means we've got more than one skin breaks in the patient's skin, and that itself puts the patient at increased risk of infection. Multiple attempts also with the human factors element. People can breach aseptic technique. If anyone who does cannulate in practice, when we go to a patient, we don't take enough equipment for 4 cannulations, do we? We take enough for 1, maybe a spare cannula, if you're really thinking about it, maybe a spare flush. But generally speaking, if you then have more than one attempt, how many practitioners go back and get all the equipment, or how much is reused for a different site in the patient's body? We can often end up with suboptimal insertion site as well. So the optimum insertion site for a cannula is in the forearm first, and then we would maybe move to the hand. if you were in normal clinical practice, not vascular access usually. But obviously, when you can't get a cannula in that optimum site, then we would usually move to other areas, one of them being the ACF, which is great because it's usually get a vein first time, and everyone loves the ACF, particularly in A&E. But obviously, this site is prone to dislodgement, infiltration, and then you've got the knock-on problems of potential infection and extravasation. It results in lots of wasted resources. I've included length of stay because I actually do think it's difficult to equate, but if your patient has multiple cannula failures, they're not getting their optimum doses of their IV antibiotics, for instance. If they don't have their CT scan or MRI scan because they don't have vascular access to do that, then that would surely have an impact on their length of stay. And also reduce patient satisfaction. I mean, that's kind of a gentle term for it. Some of these patients are really going through it. We have patients who come to us and they say, well, they had 10 attempts yesterday, they had 15 attempts. Each cannula is lasting 12 to 24 hours at the very most. I had a patient yesterday who said, I made them stop after 2 attempts. And you think, 2 attempts, that's not a lot, not for a patient with difficult IV access. But she said, I was crying because I knew what they were going to do. I knew they were going to keep trying to get access. And then the next day we seen the patient. So, talk about this patient that I seen yesterday. This patient's had difficult intravenous access. So this is the literature surrounding, some of the literature surrounding it. So if anyone doesn't think that difficult IV access is a problem with this organisation, in their organisation, I would kind of say, well, actually, it's a problem across the board. Patients are getting more complex. Patients are living longer. Approximately a third of patients require at least more than 1 attempt to gain access. Around a third of patients who require a cannulation do have difficult access. And what this means is no visible or palpable veins and multiple attempts to gain IV access. Also, a history of intravenous drug use, obesity, malnourishment, and also previous chemotherapies can also contribute to DIVA. This is a DIVA assessment tool that has been used by Braun, which has been adapted from some literature. And what's interesting about this is that it points to the fact that have you got a history of vascular access? Is the veins visible? Are the veins palpable? And does the clinician expect to have difficulty inserting that cannula? Well, we've got this DIVA assessment tool, and a lot of places are starting to use something similar or the same, for instance, in the clinical areas. But actually, if I go to one of the wards in my organisation and I say to a nurse, I say, which one of your patients got poor access? They'll go, Mrs. Smith, Mrs. Jones, in a heartbeat. A lot of people don't actually need an assessment tool for their patients, some do. But you just can look at a patient sometimes and know that they've got poor access. So why ultrasound-guided cannulation? Well, it's because you can see beneath the surface of the skin. That's what it is. And there are other devices out there, so infrared, for instance, where you can also see veins. But ultrasound, to me, you can't get better than ultrasound. And the reason is that you can see all the structures in that patient's arm, because we only cannulate in the arm. You can see how deep the vessel is. You can see if it's compressible. You can see if it's got flow. You can see the surrounding nerves and arteries. And it enables insertion of a device that is less invasive than the alternatives. And also, it's accessible to a lot of people. How many healthcare providers within hospitals and the community provide cannulation? There is a lot. It also allows you to insert the shortest, least invasive device for your IV therapy, but also can be a bit ambiguous, which if we have time, we can talk about at the end as well. And it also helps to prepare upper limb vessels if you need them for current and future health needs. It sometimes provides a bridge temporarily if you're making decisions about the patient journey and they may need a long-term device further down the patient journey. So this is where we talk about what we did in the hospital I work in. So we had a problem a few years ago. We still have lots of problems now, but this particular problem is that we were putting more invasive devices in for patients than what they needed. When peripheral access was impossible, they would be referred to us and we will put in a rescue procedure which included a midline or a PIC. Generally speaking, it was always a peripheral midline because we had nothing else. That's what we did. That was quite normal. I look back now and I'm quite horrified. I'm like, I can't believe we actually did that, but we didn't have anything else, so that's what we did. We looked into our data and found that over a third of patients really only needed peripheral cannulation, but because of the difficult access, we put a peripheral midline in. Sometimes we put a PIC in because the clinical teams told us a little bit porcupines and said they needed a PIC when actually they just were so desperate for access they needed something. A longer length device became available at that time, and we trialled it and we used it. And at first, we didn't really know how it was going to fit in our clinical practice. This was back in 2019. We thought, okay, obese patients, it would work very well, maybe for a couple of days of treatment. And we, at that time, thought, this is going to be really easy. We can put PICCs and midlines in. This is going to be a breeze. It really wasn't a breeze. It was really hard to actually develop a technique, because it's not like the traditional PICC and midline placement that I used to do. And it's not like normal cannulation either. It's something in between. And that's, I think, why there's a steep learning curve associated with it. During the time, we altered our insertion technique, so we used a dynamic technique more, and we developed that. So obviously, you've got to make sure you follow your cannula completely with ultrasound until it's sited safely. And that is the key, amongst some other things that we found contributing to success. We also had some dislodgements with the longer length device to start with. So we used an additional securement, which you've seen on the picture at the beginning, which was like an over-the-top stat lock. That was introduced, and that contributed to a reduction in dislodgements for the cannula too. And we also used a larger dressing, because we tried the little ones and we were just like, this is really not going to work. Although it's a very narrow device that we use, so long, we needed to have that larger dressing. It was very patient-led. When we started to implement this, we weren't sure how successful it was going to be, but it absolutely sold itself. When we offered this, we put one little brief thing in the trust comms and said, oh, by the way, we offer this now. We were inundated with requests, and that is because it's a good device. It's a fantastic technique. We still get calls, and they renamed it. They called it, like, can we have a 7-day cannula? And I was like, it's not a 7-day cannula. And they were like, but that's what the staff named it. That wasn't us. And then also, what we did is we involved patients from the start. And it was interesting, someone mentioned before about informed consent and cannulation. We actually have a trust patient's information leaflet about cannulation with all the risks in. I don't think I've seen anyone ever give one out to a patient since I've ever worked in a hospital. However, when we did this, because this was quite a new technique, we give all the information to the patient and said, look, this is what we can offer you. We can carry on with what we did before, or we can try this new cannula. We don't know how well it's going to work. This is all the things that could happen. And to be honest, most of them really liked it and wanted to try it, and it worked really well. Device surveillance. So we surveilled these devices from when we started to use them to when they were removed. And that gave us some really good evidence, and it gave us the assurance we needed, because we were using a new technique and a new device. Because without that, we didn't really know how well it was going to work. If we had an increase in complication rates, we really needed to know that, because we needed to keep patients safe. So we've seen the patients every day to start with, which the team really weren't that happy about, but they sucked it up and got on with it, to be fair. And then once that we realised it was implemented well, we dropped our surveillance down to weekly, and we still do that now. So we still see the patients after 7 days to see if the device is still functioning, to see if they still need it. And if they still need it, it's kept in place, and we do the dressing and the needle-free connected change for those patients, which is good to remember when we talk about the results. So when we think about patient assessment, as I say in the beginning, we didn't know who would be the best candidate for this device. Over time, when we looked at our surveillance results and we realised how long they lasted for, then it really informed our patient assessment now. So what we do now is that if someone needs peripheral access for up to 1 week, they will automatically be offered an ultrasound-guided cannula. Sometimes we offer it in other circumstances, but it's very patient-dependent. So if someone's got a PICC line in, for instance, that can't be used, or if someone's got a Hickman line that needs repair, we will sometimes bridge them with a cannula, because it gives us that leeway, especially in the poor access population, because normal cannulation is not an option for them anymore. We have to look at vessel size and cannula gauge. We found that vessels in the lower arm with the larger cannula gauge and the longer cannula gauge together, so it was a larger one and a longer device, we had more phlebitis with those. So generally speaking, we don't put them in the lower arm. And also vessel location and depth. You obviously need to put it in the right location for that patient, because obviously there's no point trying to put a longer cannula in here if it's going to go over the ACF or too close to the wrist, for example. And also the depth of the cannula. It does dictate how long your device needs to be. If your vessel is 1 centimetre below the surface, if you're going at a low insertion angle, it's going to take you further cannula to actually reach that vessel, okay, which we'll talk about a little bit as well. So I've just put this slide up to talk about the vessels that we choose and not choose when it comes to intravenous cannulation with longer length device. So we would always try and put them in the lower arm. to start with, as long as the patient's got suitable vessels. And what I mean is usually when they've actually got vessels that you can actually access with ultrasound. So we would use the cephalic and basilic veins in the lower arm. We would always avoid the ACF for obvious reasons that I've already mentioned. We do put this device in the upper arm, so we would always try and go to the superficial veins. We would usually use the cephalic and we would avoid the deeper veins, because what we're trying to do is avoid those deeper veins in case they're needed for something else. Nothing can ever be black and white. There are some patients where we do bend our own rules, but that just goes on the patient's situation at that time. I can think of one patient who was in A&E and they were very, very poorly. None of the consultants could get any access on the patient, and all they had at that time that was suitable to access quickly was their patient with it, was their own basilic vein in the upper arm. I would never normally choose to do that, but we did it. I seen the patient a week later and he was well and it worked for him and he went home after that. So it can work. So this is a slide about technique, and I think this is really important to mention. So the three pictures that we can see, it's a bit of like the Goldilocks effect, I think. Things just have to be just right to make it work well and to make the device last, okay? So we've got the insertion angle on the first little crude picture. The insertion angle is too steep. If when you're cannulating with a longer length device, if your insertion angle is too deep, if you're going to go in at a 45-degree angle, it's most likely going to kink after you've inserted that device. You probably will get into the vessel, but then it's going to hit the vessel wall and it may work and bleed back for you and flush normally when you've put it in, but we found that when you walked away 1, 2, 3, 4, 2 days later, it actually dislodged or stopped working. We found that when we implemented, but that's also reflected in some of the literature as well. I've looked into ultrasound-guided cannulation. The second one is that the cannula is too short, and that is why I can't emphasize enough the need for a longer length device in this patient cohort. The reason they've got difficult access is that most of their vessels are deeper below the surface. So what you can see in this one is that we've got a lower insertion angle, but the cannula is too short. So it's just going into the top of the vessel, but you don't have the catheter vein ratio that you need. So you need approximately 2/3 of that catheter to be inside the vein to get successful device which won't fail prematurely. And as you can see from that second picture, it's only just inside the vessel. You may well put it in successfully. Once again, it'll probably fail afterwards. And my third picture, which these pictures do make me laugh a little, but they're quite crude, is what I'm trying to demonstrate is what you get with the longer length device. You've got a low insertion angle. You've got the longer length that can travel through the tissue of the deeper vein, and then you're still getting a decent amount inside the vessel too. And that's what we found is kind of the perfect thing that you need. And when it comes to technique, it would be remiss of me not to mention about dynamic ultrasound technique. You always need to follow the tip of that device when you're doing cannulation. This has actually helped me as well with my line placements. It's made me better as a line placer because I do cannulation as well, which is kind of weird. When we started as well, sometimes you think you're looking at the tip of the cannula, but you're actually not, you're looking at the shaft. And you always need, and when I teach about ultrasound-guided cannulation, I say you're always further in than you think you are. You always think you're looking at the tip, but it's only when you move your probe away from you, you actually say, no, the tip is actually further in. And then if you're failing with ultrasound-guided cannulation, that's the most common problem that you will find, because you think, I'm in, I know I'm in. But actually, you've gone way further. You've hit the bottom of the vessel wall. So when you try and advance your cannula or flush it afterwards, then you're going to hit problems. So these are the results that we found. And anyone who's got quick maths, I haven't got quick maths, you will see that the total cannulas in the table is not the same as the top number. Deliberate mistake. Well, actually, it wasn't a deliberate mistake. I took the total devices from, these are complete years in the table, and the top number is some additional devices when I'd written the presentation. So we have a 90% first time success rate, and then I think we've got an 8.7% second time success rate. So basically, it's highly successful technique and device. Our average dwell time is 7 days. Now, this excludes the patients that we put in for 1 day of treatment. So we have a lot of outpatients that we see who need procedures either in gastro or radiology, and they're outpatients, so their dwell time is always a day. Well, it's actually probably about an hour, but we always put it down as a day. So excluding all those people, we have a 7-day average dwell time. And almost all of these devices are in the forearm, which is the optimum place. And if we think about DIVAs, most DIVAs don't actually have forearm cannulas. They don't, unless they have something like ultrasound-guided cannulation. They usually end up in the shoulders, feet, fingers, knuckles, all those kind of things, which is not nice for anybody. And if we look at our results, as you can see over the years, we've put increasingly more in devices every year. I think we put in about the same number of cannulas that we do with all our other lines, which is quite a lot now. And we've got persistently low complication rates compared to cannulas as well. So this is just a little bit about the advantages and disadvantages of this technique. It does provide access in patients who used to be impossible. They are no longer impossible. There is a very small amount of patients that can't be cannulated, but I actually can't think of many at all. I think there's the small amount of patients where you put a cannula in and go, actually, I don't think that's going to last, but we'll see how it goes. And some of them do, and then some of them you have to escalate to a more invasive device. Ultrasound is fantastic because it's safe for the patients. It enables comprehensive assessment of that patient's veins, which you don't get with blind cannulation. You just don't get that. Because a lot of cannulation takes place where the cannulas aren't necessarily visible or palpable. It's on the expertise and the anatomical knowledge of the cannulator, and they're very good at it, so they can still cannulate successfully. It allows access into the deeper vessels so that you can insert that longer length device, and it also enables the increased catheter vein ratio, which prolongs the life of that cannula. The literature tells us that about 2/3, some are more specific, saying like 2.5 centimeters or more, but basically the majority of that cannula is within the vein, not within the tissue. And that's really important to get successful and longevity out of your device. I believe we can make cannulation work much harder than we do now. I think there's a lot of complacency around cannulas, and it's seen as a disposable device. To me, it should go in, and we should apply the same principles of any other line management to a cannula. You can get extended dwell times for these devices, and they're also good because they buy you time. We get a lot of patients where we probably know they're going to need a more invasive device, but we're not 100%, or there's something going on with the patient, like they are septic, they've got positive blood cultures, they don't really want to be putting a central line in for that patient. So we can tide them over because we know we can put a reliable device in that will enable them to receive their IV therapy as well, until those decisions are made. It's great because it's also not role specific. Within our team, we've got support workers who are absolutely fantastic, and they were trained in ultrasound-guided cannulation as well. And I know other people have published, and other people around the world have also done this. People who have never worked in healthcare, for instance, have come in and been able to do this as well to a high standard. It is adaptable wherever cannulation is performed, so I see this being used as well in community settings. I think some people are starting to do it, but it absolutely can be used. It's anywhere cannulation is used, we should be trying to do ultrasound-guided cannulation as well. And we know it reduces rescue procedures. That is well documented in the literature. I don't have that data myself. I'm afraid there's a big piece of work to try and see if it reduces our rescue procedures, but we know that it does do that. So the disadvantages are there is a steep learning curve. If you're in the middle of trying to do this or implement it in your organisation, there is a steep learning curve associated with it. We found that we were all experienced inserters in line placement, and we did find difficulties when we initially started to do this. It requires you to be able to look at your own practice, reflect on it, change your practice, and also involve the clinical teams and the patients to give you feedback as well. It does require access to ultrasound. And also we need to remember that it's not infallible. No, to me, no vascular access device is perfect, not one of them. I wish there was. Maybe I should try and invent a perfect vascular access that will do everything for everybody, but it's not there. It is bound by the limitations of cannulation. So it is associated with extravasation, phlebitis, bloodstream infections, and sometimes with the access in the deeper vessels, sometimes your complications can become apparent a little bit later because they're deeper, so you've got tissue to kind of get through. Your phlebitis can sometimes show itself a little bit later in the journey. And also it's not suitable for those very, very deep vessels. Probably the deepest we would really go is about 1.5 centimetres. I think I've maybe pushed it to 2, but obviously when you've got a very deep vein and you've got a 64 millimetre length cannula, then you've got a lot further to travel the deeper that vessel is. And I've got some time for questions. Just like to finish and say that I do think this should be rolled out in all healthcare organisations. I don't think everybody can be trained to do it, because you've got to be able to gain the skill and keep the skill. But there should be key people across organisations who are able to do this 24/7. We're not there yet in our organisation, but that's really what we're aiming to do. Thank you much for listening, and if you've got any questions, or if you've got time for questions, I don't know.